Welcome to this explainer. Today, we are diving straight into the incredibly high-stakes world of pediatric documentation. If you're a clinician, a medical coder, or a CDI specialist, you already know that treating kids, well, that's really only half the battle. The other half is navigating this complex, honestly sometimes overwhelming web of strict, legally mandated documentation standards, developmental tracking, and psychosocial risk screening. So we're going to look at exactly how the day-to-day realities of pediatric care align with the rigorous 2026 AHIMA and ACDIS compliant query guidelines. Here's our roadmap for today. We're following a continuum of care approach. We'll start with 1. The stakes of pediatric CDI. 2. Vaccine documentation and refusals. 3. Anticipatory guidance standards. 4. Adolescent psychosocial risk screening. And 5. Child maltreatment and reporting. All right, let's kick things off with Section 1, the stakes of pediatric CDI, where we'll look at evolving patients and evolving rules. Now, because our pediatric patients are literally constantly evolving, we absolutely have to rely on compliant queries to capture their complete clinical picture. Under the 2026 AHIMA guidelines, your queries must be non-leading. They have to be based entirely on objective chart indicators. You just cannot introduce your own subjective interpretation or kind of nudge a provider toward a specific diagnosis. For instance, if you spot social red flags, there is no way you can just ask them to diagnose abuse outright. You have to use a clinical validation query that cites objective facts, like, say, fading bruising, which allows the provider to exercise their own independent clinical judgment. And this is exactly where standardized forms become your absolute best friend. Templates from EPSD, which is the Medicaid's Early and Periodic Screening, Diagnosis, and Treatment Program, along with the Bright Futures Initiative, are perfectly designed to capture those exact objective indicators we just talked about. From growth screening all the way to immunizations, these forms actually guide providers to ask the right questions and document the concrete objective findings that both public and private payers demand. Moving right along to Section 2, vaccine documentation and refusals, focusing on documentation compliance. So every single pediatric visit is an opportunity for vaccination, right? But the documentation for it is heavily regulated under the National Childhood Vaccine Injury Act. You can't just scribble vaccine given in the chart. By law, your documentation must reflect the Vaccine Information Statement, or VIS, publication date, the date it was actually provided to the family, the vaccine manufacturer, the lot number, the administration site and route, and of course, the expiration date. If you miss just one of these elements, that is a direct compliance failure. But what happens when a parent just flat out says no? Well, this is where professional liability becomes a massive issue. If a parent refuses a vaccine and that child later contracts the disease, your documentation is literally your shield. Look at the specific medical legal phrasing required here. You have to explicitly prove that risk counseling occurred, that the real consequences of not vaccinating were thoroughly explained, and that educational materials like that VIS were provided and discussed. Okay, Section 3, Anticipatory Guidance Standards. Let's look at promoting health and safety. Here we're shifting from preventing disease to actively promoting safety. This timeline maps out age-specific anticipatory guidance, and it's fascinating to see the evolution. At 2 weeks old, your documentation must reflect conversations about safe sleep positioning and rear-facing car seats. Then, by 6 months, we pivot to things like choking prevention and starting solid foods. Fast forward to 5 years, and the chart really needs to show counseling on school readiness and setting strict screen time limits. So I want you to ask yourself, is your chart capturing the why, or are you just checking a box to get through the encounter? The 2026 guidelines make it very clear that ambiguous documentation requires clarification. If a developmental delay is suspected, for example, you can't just leave it vague. The chart has to contain objective findings from established tools like the Denver Developmental Screening Test or specific parent questionnaires to support any clinical validation queries that come up later. Shifting gears to Section 4, Adolescent Psychosocial Risk Screening, we're going to dive into GAPS and behavioral risks. As your patients enter their teens, medical risks shift heavily toward behavior. To compliantly uncover these psychosocial risks in a confidential setting, providers use the GAPS guidelines and the HEAT SSS 3.0 assessment framework. This updated version critically steps through home, education, eating, and activities, which now heavily factors in media and screen usage. Then it covers drugs, including vaping and ENDS, sexuality, suicide and mental health, and finally, safety. And crucially, this structured interview ideally needs to be documented as having occurred without the parents present in the room to ensure you're getting an accurate risk capture.
Now, because intentional violence is such a major threat, 3 out of 4 adolescent deaths are caused by unintentional injury and violence. The FISTS mnemonic is a totally crucial screening tool. It prompts providers to document exposure to fights, injuries, sexual violence, threats, and self-defense strategies. Actually, documenting these exact questions gives you the necessary clinical indicators just in case a life-saving safety intervention is required down the line.
Even a seemingly routine sports pre-participation physical, under encounter code Z2.5, demands meticulous documentation. Beyond just checking vaccination and psychosocial status, the chart absolutely must capture rigorous personal and family cardiac risk screening. We're specifically looking for red flags for things like hypertrophic cardiomyopathy, syncope, and sudden cardiac death. And for female athletes, your documentation must also evaluate the female athlete triad, which means screening that critical intersection of eating habits, menstrual cycles, and bone health.
Finally, we reach Section 5, Child Maltreatment and Reporting. Let's discuss mandatory reporting obligations.
This is the area where clinical documentation integrity, ethics, and the law intersect most sharply. What you're seeing here outlines the clinical indicators for the 4 types of abuse: neglect, physical, sexual, and emotional. To give you an idea, a child with severe body odor who lacks weather-appropriate clothing, that points objectively to neglect. Unexplained or fading bruising, where a parent is offering conflicting explanations, that points right to physical abuse. These exact red flags have to be meticulously recorded. When you are generating a clinical validation query for suspected maltreatment, your query must remain completely non-leading. You just cannot make a subjective assumption in the record like, the parent is abusive. Under the 2026 query standards, you have to quote the exact physical findings and behavioral observations documented in the chart, like fading bruising, and use that to ask the provider to clarify the condition they are treating or suspecting. Under laws like CAPTA, healthcare providers have a strict legal obligation to report suspected maltreatment. But listen, reporting isn't enough. It must be backed by rock-solid, objective documentation in the permanent medical record for Child Protective Services. This means detailing the patient's psychological demeanor, utilizing body diagrams to map the exact location and healing stage of injuries, and including properly identified photographs taken with consent. Finally, the chart has to clearly state exactly to whom the report was made and when.
So I encourage you to take a really close look at your EMR templates today. From vaccine not numbers all the way up to objective abuse indicators, your documentation is the ultimate safeguard. Leave today asking yourself this final critical question. If your pediatric documentation were scrutinized in a court of law tomorrow, would it tell a complete, undeniable story of a child's life and health, or would it leave them vulnerable? The choice really is in the chart. Please like, share, subscribe to Decode Healthcare with Herschel.